Good morning, everybody. It is so wonderful to be here. I have been a health journalist for 25 years. And in that time, most of what I've done is tell other people's stories. That changed pretty dramatically last November when I got a call from Northwestern University. I was told they had a new longevity study that was getting underway and a new longevity lab. Did I want to cover the initiative? And better yet, did I want to sign up to participate in it? I thought about it for a while, and about a month later, on a very snowy day just before Thanksgiving, I found myself on the elevator of the Northwestern Memorial Hospital. I took it to the 21st floor, got out. It felt much more like a spa than a hospital. I was looking out to the shores of Lake Michigan. And for the next 12 hours, I was poked and I was prodded, and I literally rolled up my sleeve for science. I had my blood drawn, and they did dozens and dozens of tests for the purpose of trying to understand what was the difference between my chronological age, which is the date on my birth certificate, and my biological age, which is my rate of aging compared to my peers. What I found out was fascinating, and what the goal of the study is to figure out what interventions can be made to slow down the rate of aging, which is exactly the work of everyone on the panel here. So to get this started, I'm going to do a quick lightning round. I'm going to do some quick introductions. And I want everyone to ask the same question of themselves. You guys all showed up here because the name of this panel is, Can I Live to 100? So I want each of you to think about that in your own minds. And a quick lightning round up here to each of you. Can you live to be 100? And do you want to? And we'll start down there with you, Dr. Lloyd Minor. He's Dean of the Stanford Medical School and a personalized medicine expert.
Yes, I think increasingly we can live to be 100. Would I want to? Depends on whether or not I can be healthy and if I can continue to contribute to others.
Got it. Kristen Fortney, she's co-founder and CEO of BioAge, which is a clinical stage biotech company basically developing drugs to extend lifespan.
Yeah, just to add to that, I think we can even move the average lifespan to 100. I think it will require scientific innovation, new medicines, and again, we want to make sure that we're living healthier, not just longer.
Dr. Peter Diamandis, founder of the XPRIZE and the new health span competition. You are an author and a longevity expert. Do you want to live to be 100?
I think 100 is a lowball offer.
Very good.
120?
Let's save that for the conversation later. Let's add a few not orders of magnitude, but a few multipliers on that.
A few multipliers. All right, Dan Buettner.
I like that attitude.
Yeah.
Okay.
So the average maximum life expectancy of the human species right now, in other words, if you have an average set of genes and you live in the developed world, you can expect 94 years. Reaching age 100 right now, you have to have won the genetic lottery. But that said, since 1840, life expectancy of humans has gone up about 2 years per decade. So I'm 63 right now.
No.
And I expect, so if I expect the 94 I got coming to me, about an extra 2 years per decade, so I should be able to hit 100 right on the nose, and I'd be very happy with that.
Right on the nose. I love that. All right. So, Lord James Bethell, you are now in the House of Lords. You were Minister of Health during the pandemic. You're very interested in how to incentivize healthy lifestyles in the UK. Can you live to 100, and do you want to?
Yeah, no, it's my full intention. I am working on it. Okay. The amazing thing about the House of Lords is it's a job for life. You have it till you die. And I can't tell you how good peers look. The members of the House of Lords are so motivated and have such a strong sense of mission about their roles that they really live forever, it seems. My office mate is 94 years old, and he's still going strong, and that's definitely my full intention. It shows the sense of mission is so important to getting people to live for a long time.
Peter, health span longevity is a mega topic right now, something everyone is talking about. If we could think to living to 120, when can we start to see this? Is the science of aging and longevity, is it going to propel us forward in this decade?
So let me interpret that in a different way and say, why now? So 2 reference points. I agree with everything Dan said. You've got a few species on this planet, like the bowhead whale that can live to 200 years, and the Greenland shark that can live to 500 years, have babies at 200 years. When I was in medical school, I asked the question, why can they live that long and why can't we? And I said, it's either a hardware problem or a software problem. And it's this decade that we're getting the tools to understand how to address the software and the hardware problem. And so the why now comes down to 3 or 4 reasons. 1, there's more capital going in year on year on year. People have finally realized they can't take it with them. That's a big win. The second is the whole AI revolution. AI and longevity, as we were discussing, are converging. Quantum technology, quantum chemistry that's coming in the second half of this decade. Advanced diagnostics to catch disease at stage 0, and then a whole onslaught of therapeutics. And so those things all coming together, hopefully, will get us to what's called longevity escape velocity, which is today we're at 2 or 3 years per decade. There'll be a point that for every decade you're alive, science is adding more than a decade to your life. So when people say, what's your longevity goal? I used to say 700 years. I now say to get to longevity escape velocity.
Got it. There's sort of 2 sides to this coin. There's the behavioral side. What can we do right now to be healthier through our daily habits? Then there's also the cutting edge technology, biotech. Kristen, I'm going to come to you next. Your company is now partnered with Eli Lilly to run a phase 2 clinical trial looking at combining a compound that you have identified in your company and combining it with one of the GLP-1 agonist drugs, which are the blockbuster weight loss drugs. Do you now see this class of medications, these weight loss drugs, as potential longevity drugs?
Yeah, that's a great question. And certainly if you think about what longevity drugs are on the market today, they're arguably the best ones we have in the sense that they have the chance to move the average lifespan of the entire population, right? They probably can't do much for you if you're already in great shape, but half of America isn't. And these drugs, as you know, are not only causing weight loss, but they're also protecting you from cardiovascular disease, protecting you from Parkinson's even. That was the most recent finding, which I think was a surprising finding even for the scientists in the area. And what I love about that, as a scientist working in the aging area, is that those of us trying to build companies in this space are really inspired by the idea of building medicines that don't just treat disease once you're already very sick, but that have the potential to prevent or delay disease. And until a couple years ago, the best example I had of a therapeutic that was actually like that was a statin. Statins were first approved for a rare orphan disease. It took 20 years for them to be used in the way they are today, where they're actually used by most older people to delay disease. But now there's the incretins, these GLP-1 drugs, Mounjaro and Wegovy, that are making an impact really quickly, and I think are increasing the appreciation of the power of medicines that can really delay disease. And this is the area that we work into at BioAge.
And you're going to be able to get an answer to your question pretty quickly. You have a clinical trial starting, and within a year, you're going to know something. Is that right?
That's right. So again, those of us working on aging medicines too, if you have a drug, you think it has the potential to slow aging, what do you actually do in a clinical trial? You can't actually see if your drug makes people live longer. You don't want to run a clinical trial for 10 years. That's not practical. But you want to go to a particular disease first. And we really like obesity because it is a condition that does accelerate many facets of aging, especially in older people, where you have increased risk of cardiovascular disease, increased risk of diabetes, and where, yes, you can prove efficacy really quickly. So our lead program has the potential to increase weight loss in an oral form and also promote healthy weight loss. And these trials take about 1.5 years. Yeah.
Great. Dan, I want to move over to you. Let's talk a little bit about the communities and how community shapes health. You have identified places where people are more likely to live to 100. Okinawa, Ikaria, the Nicoya Peninsula in Costa Rica. These are places that are usually sort of rugged, far off. The pace of life is very simple. The way people eat is very simple. It's night and day from the 24/7 lifestyle that many of us have here. Do you think it is possible to export what you have seen in these blue zones, as you've called them, and bring it here to this modern culture that we're living in?
I know it is. And the value proposition these blue zones that middle-aged people are living an extra 10 years. So this isn't a theoretical or algorithmic hope. It is real human beings with an average set of genes who are suffering 1/5 the rate of cardiovascular disease in some cases, 1/6 the rate of type 2 diabetes. And by the way, it's those diseases that are driving about 80% of our $4.4 trillion annual healthcare cost. So what I've tried to do is find out exactly the constellation of policy and nudges and lifestyle characteristics and bring them to American cities. And I've worked now in 20 American cities with these publicly supported, privately funded Blue Zones projects, where we don't try to go into a city of 1 million people like we did with Fort Worth, Texas, and convince them to eat peasant food or to walk or to get on a certain set of supplements or drugs. We simply change their environment to engineer their unconscious choices, so they're silently nudged into moving more, eating better, socializing more, and living their purpose. And when you look at the policy environment, restaurants, grocery stores, workplaces, schools, and then individuals' home, and you hire a group of people who focus on that for 5 years, in every case, as measured by Gallup, we've seen the BMI go down, healthcare costs go down, and life expectancy go up. Real people, not only rich people who can afford heroic interventions, but poor people, where I think the greater opportunity lies.
But there's an uphill battle here, right? I mean, right now in the United States, 100 million Americans have prediabetes. By age 50, half have these lifestyle-related chronic diseases. Do you think it's possible at this point to take people who are inured in this environment and help them make these personal lifestyle changes?
Yeah, you cannot rely on individuals. You know, we spend $150 billion on diets, and if you look at the very best diets, they start out with a lot of steam, but you lose about 90% of them in 7 months, and you lose 90% of them in 2 years. So diets aren't working. Exercise programs, you start in January, you lose about 80% by the end of the year. Even if we'd come back from the Blue Zone with a pill or a supplement guaranteed to reverse aging, if you look at the recidivism curve of pharmaceuticals, you would lose almost all of them within about 4 years of people starting to take drugs. So the answer really is not trying to convince people to change their mind or change their behavior. It's changing their surroundings. And the reason I know that would work, in the 1980s, many of us were alive then, we had about 1/3 the rate of obesity, 1/6 the rate of type 2 diabetes. That isn't because they had better longevity programs or they had better supplements or because they had, they were more disciplined or better people. The environment then was we spent about a half the amount of time we spend in our cars today. There were about 1/20th as many fast food restaurants, and we didn't have groceries showing up at our front door. We had to actually go out and shop and interact with our neighbors and carry our groceries out. I believe in what Peter and my other panelists believe in. I think there is going to be a time when we're going to have a major breakthrough. We can't see it yet. The pace of discovery is such that they're probably right. But until then, Americans could all get about 10 extra years of life expectancy and slash our annual healthcare costs, I think, by paying close attention to these populations that actually achieve the outcomes we want.
James, I have heard you call the National Health Service in the UK the National Sick Service.
Yes.
Here, you will often hear people say that the US healthcare system is not healthcare, it's disease care. Talk a little bit about what you mean by what you see in the National Health Service and what the problem is as you see it.
So we have many of the same problems in the UK as the US, particularly around things like obesity, cardiovascular, respiratory diseases. And the underlying drivers of that are often overweight, hypertension, lack of activity. It's the environment that people live in that is really affecting their long-term longevity. And if we're going to give team longevity the best chance of escape velocity, we need to put pretty healthy people into the hopper in the first place. And that's not going to happen if they're in a sick environment. So we're actually going quite a lot further. And I do agree with Dan about the importance of the built environment. but we are doing taxes on sugar. We're bringing in a smoke-free generation law that prevents younger people from ever picking up smoking. We're bringing in gambling, profits taxes. We're doing a whole bunch of quite big interventions to try to improve the environment. And the interesting thing about it is that they have very strong political support from families, from voters, from taxpayers. The penny has dropped amongst the British voter that we can't live in this environment that is making everyone sick and creating a huge dropout from the workforce that's hitting our economy really hard. So ultimately, I'd like to see some hospitals close, and I'd like to see some taxes spent on the kind of prevention measures that we were talking about earlier.
You would like to see hospitals close?
Oh, for sure. People don't like hospitals. You know, I was in an election in the UK in 2019 when Boris won the election, and our big commitment was we were going to build 40 new hospitals. And we thought that that was a piece of sort of electoral genius, and it did work. NHS worked very well for the Conservative Party. But when the pandemic came, no one wanted to go to the hospitals. And since then, attendance at hospitals has dropped off a cliff. People want to be healthy, they want to be treated in their communities, they want to live in an environment where the healthy choice is the easiest choice. And so, yes, I would definitely like to see some hospitals close.
Lloyd, I want to move down to you. You are Dean of the Stanford Medical School and training a new generation of doctors. When you think about this, how is the curriculum changing or the thought process changing to try to train doctors in preventive care? And do you think within your lifetime, doctors will be prescribing longevity regimens or anti-aging drugs?
Sure. Well, to pick up on some of the points that the other panelists have made, I think, you know, in the United States, we really have a sick care system, not a healthcare system, just as James was describing in the UK. And, you know, making that transition is both a transition in how we deliver healthcare, it's also a transition in how we think about doing and applying the science related to biomedicine in a more predictive and preventive way. And that really begins with the research we do at academic centers and companies and other places, and also the way in which we train the next generation of leaders, both leaders in terms of the delivery of healthcare and also leaders in terms of driving biomedical research. You know, a lot of the fundamental science and the early translational science that we've used to develop so many new therapeutics, and it's important not to take for granted that the advances we've seen over the past 10, 12 years in cancer, for example, with immunotherapy, you know, eclipse what we'd seen in the previous 30 years, and we're only at the very beginning. So we shouldn't turn our back on improvements in sick care, but those same advances and those same approaches can be applied to developing better predictive measures, developing better early interventions, or even preventing disease entirely through understanding the mechanisms that ultimately lead to the development of disease. And then finally, back to the medical education front, you know, we have to also look rigorously at the social, behavioral, and environmental determinants of health. A lot of the comments made already on the panel today have underscored what an important role those determinants play. Maybe 60, 70% of our determinants of health come from social, behavioral, and environmental determinants, the rest from the medical care we receive and our genetics. But we need to devote the same degree of scientific rigor and educational rigor to understanding those determinants and developing more affirmative interventions in addition to talking about them and studying them and making the statement about their importance. It's still a sad fact in the United States that the zip code in which a person lives is a better predictor of their life expectancy than their genetic code. We know some of the reasons for that, but we haven't devoted nearly enough attention to the science behind the interventions that can be effective at addressing those reasons.
Say more about the zip code. I came across this in some reporting I've done recently. I was looking at the average life expectancy in Princeton, New Jersey, 92 years old. You could put a ladder up in Princeton, New Jersey and look down to a much poorer part of the state and see a zip code where people are likely to live 20 years to 70 or so. So 22-year difference in lifespan in zip code. Say a little bit more about how these social determinants of health play such a big role.
Sure, well, there are a variety of social determinants, but the access to food supply, the access to physical safety in environments that have high crime rates are associated, of course, with higher rates of gun violence, are associated with lower life expectancy. But back to what Dan was saying, and it's something that I think is really impressive about the work that Dan, many things, but impressive about the work that Dan and colleagues are doing. How do we learn from blue zones? We might call them indigenous blue zones. And how do we take the principles and apply those in areas where maybe we never thought they'd be applicable? But I think, as Dan and colleagues have shown, there are many principles that can be implemented in cities, in communities that haven't had the same access to resources that other communities have had, and can be effective. It takes community engagement, and I think back to your point on medical education, how do we educate a generation of physicians that, yes, understand the science and have every bit the scientific rigor that underpins the practice of medicine today, but also see the way in which that science and that healthcare is deployed in communities.
Kristen, I want to move on to you. One of the surprises that I got at Northwestern University when I did the battery of tests as part of the longevity study is that it turned out that I am very under-muscled. So my BMI is fine, but when I went into a bod pod and had my body composition analyzed, I don't have enough muscle. And it turns out many women my age don't. Sarcopenia is a growing problem in the United States. You don't hear much about it, but it's simply age-related muscle loss. So I've been lifting weights and doing a bunch of resistance training to try to tackle that. But Kristen, you got my attention up last night when you were telling me that the compound you've identified, you call it azilprog, is that right? Azilprag, okay. It is that you'll be testing with the GLP-1 drug, that it seems to mimic some of the effects of exercise in the body and may help promote better body composition. Is that right?
Yeah, so azilprag is our lead compound, and it's focused around a molecular pathway called apelin signaling. And apelin, it's one of these molecules that your body makes when you're exercising, and it's been shown by some other scientists that if you add apelin to an animal, it can help recapitulate some of the benefits of exercise, improved metabolism, better mitochondrial biogenesis in your muscle. And this is a pathway that in the human data sets we analyzed, we saw a link to longevity, but also better physical function as you age. So we were initially really excited about this molecule for its potential in aging broadly and in sarcopenia, because as you mentioned, this is really underappreciated. Everybody loses muscle mass as they age, and this is really the key driver of loss of independence, of ultimately being committed to a nursing home. And importantly, too, it can be part of really a negative feedback cycle, right? Like if you lose more muscle, you're not going to exercise as much, you're not going to walk as much, you're going to lose even more muscle. And this can have really dramatic consequences. And just to give you an example, older people who suffer from a hip fracture, that dramatically increases your risk of dying in the next year. And it's not because of your bone. In every case, the bone usually is fully healed. But it's because you're immobile for so long at a stage of your life when atrophy is really very much accelerated. So this is an area that I think has been really understudied, that has a lot of potential to improve the health of aging populations.
And talk a little bit about your discovery platform. How is it that you were able to identify this compound and see its potential?
Yeah, so we invested a lot in creating large human data sets that are relevant to aging biology. And the reason being is that we think this gives us more confidence in the translational potential of a mechanism. And what I mean by that is that you might have a drug that works really great in the lab. It maybe doubles the lifespan of your worm, or maybe even your mouse. But is it going to work in a human? Who knows? Like, we're so very different. And in lots of areas of biology, human data sets have helped with translation to the clinic with clinical success. This is why you've seen Amgen buy like Decode Genetics, or why the UK Biobank is such a wonderful resource. So we've invested in creating data sets that have that longitudinal follow-up, like really you want to have samples and health records spanning several decades of people's lives to help us get excited about certain mechanisms. And part of the rationale, too, I think, is that we want to try to copy things that already work, right? I'm more excited about pathways that mimic the effects of exercise because exercise works, right? It helps us live healthier longer. I'm more excited about pathways that are differently expressed in people who are living a lot longer already, either because they have the right genes or the right diet or the right exercise regimes. So we use human data to help us get excited about the translational potential of medicines like azelaprag.
And is there a US biobank similar to the UK biobank, or where are you getting your blood samples and all this data?
Yeah, we work with a few biobanks. Like we're looking for biobanks basically that are like UK Biobank or Decode, but with one really important difference. They have to have started collecting sample when people were middle-aged and healthy, and they have to track them for their entire rest of their lives. This is actually really hard because everybody knows biobanking is a great idea today. 50 years ago, not so much. But there's a few, really forward-looking biobanks. We have some collaborations with ones in the US, in Norway and Estonia, and we look at those together.
And you literally have frozen blood samples from 50 years ago.
Yes, these biobanks have frozen blood samples that are 50 years old, which is amazing, right? Because 50 years ago, you couldn't do very much in those. And today, you have technologies where you can go and look at like 11,000 different proteins and measure those in those samples, or thousands of metabolites. You can make a big list of all the molecules in the blood. And these are technologies that didn't exist 10, 20 years ago.
Yeah. So, Peter, you founded the XPRIZE. The latest iteration of this is a health span competition. Talk about what the goal of the health span competition is, who's enrolled, and what the ultimate, how you'll determine a winner.
Sure. So those of you who don't know, the XPRIZE this year is 30 years old. We've launched 30 prizes, about almost $600 million in incentive competitions that have driven tens of billions of dollars in R&D. About 6 years ago, we started the conversation. We're always looking for what's an area that isn't moving fast enough, or where we could incentivize people to take bigger risks to drive a breakthrough, right? Large organizations, large corporations, governments don't like trying crazy ideas because they have a high failure rate. And if you have a high failure rate, then you've got people criticizing you. But the day before something is really a breakthrough, it's a crazy idea. So if you're not trying crazy ideas, where do you try and get some significant breakthroughs? So incentive competitions are a mechanism to drive that. And we turned our eyes towards the field of longevity, and realizing we can't run a competition for 30 years, we said, okay, let's instead look at age reversal as a target. And then looking one step further, it was, can we look at, in fact, as you age, you lose function. You should know this, your body was never designed to live past age 30. If you're over 30, you're on a very slow decline. That's just, thank evolution for that. But your immune system degrades, your cognitive function degrades, you have sarcopenia, muscular degradation, your hormones degrade, all these things are just going downhill, and it's pretty predictable. So the question was, could we ask teams to actually reverse functional loss, because we can measure function easy. And we decided to focus on 3 areas. Muscle, sarcopenia, muscle is like the most important thing. If you're over 60, working out and maintaining muscle is the #1 thing you can do in your life over everything else. So please go to the gym tomorrow morning. The second thing besides muscle is immune function. Can we increase your immune function back to an earlier state, which is really fighting cancer and fighting infectious disease? And the third was cognitive, because no one wants to be, 150 drooling in a wheelchair. And so we announced this competition. The goal is you have to reverse functional loss by at least 10 years, and with a goal of 20 years. I raised $141 million of capital for this. There's $111 million in prize money. One gentleman, the founder of Lululemon, Chip Olson, put up the first third of that money because he's got a muscular dystrophy that he's looking to solve. And then Hevolution put up another third of this. And we have about 300 teams entered. I hope to get that to 1,000 teams. Kristen, you are registering soon, yes?
Definitely.
Okay, good. And the competition will go through 2030. We hope we'll have a solution there. So again, this is all about reaching longevity escape velocity. If I can give you your cognitive, muscular, and immune function that you had 20 years earlier, that's going to give you the ability to continue to function in life to intercept the next set of breakthroughs. We're at a very important part of this longevity curve. So That's what we're doing with the XPRIZE right now.
So as we are waiting for breakthroughs, I'm interested in what you all think about the longevity hacks that are kind of hidden in plain sight. I know for me personally, as I've read a lot of literature and interviewed many, many experts as part of my longevity series at NPR, one of the things I was struck by is there's some pretty convincing data on the power of optimism, right?
Yeah.
Like, isn't that hidden in plain sight? Isn't that something that...
Power of what?
Yeah, pardon me?
Power of what?
The power of optimism. Yeah, right? So people who have a set point of optimism live about 15% longer.
Can I give you the numbers?
Yes.
It was a study published in the National Academy of Sciences, 69,000 women, 1,500 guys. And it was shown that optimists live on average 15% longer than pessimists. So it's a double benefit, right? It's like really great to be an optimist and you live longer. I mean, what's to lose?
I mean, there's toxic optimism, right? Like if you're just completely not seeing reality. But the thing that really struck me about the optimism is, along with that, there have been a series of studies published that are called best personal self studies. So people think, oh, you know, you're either an Eeyore or you're happy and rosy personality, that it's a set point that you can't change. Turns out you can. There's actually 3 or 4 studies to show that you can move the needle on optimism by practicing these exercises of best personal self. So again, you know, these are things that are hidden in plain sight. They're things that we can do every day. When you think about the low-hanging fruit of longevity and habits that are linked to longevity, what are your best hacks?
So I was just in Italy. I'm doing another project. I found the area, working with global burden of disease, found the areas where people live the longest health-adjusted life expectancy. So they're living about up to a dozen more years than Americans are without disability and without chronic disease. And it's only this one region in Italy. So I start looking around, what are they doing as producing this? And I had to go back in history. And I went all the way back to Pope Sisto V. Pope Sisto V took over this particular area, and he didn't want any big landowner to usurp him in power, so he gave all the peasants a little piece of land. And to this day, when you drive through this area, it looks like a green patchwork, like a huge green quilt. So you start asking around what people do with their lives, and it turns out 93% of people have their own garden. So what does a garden mean? Garden means that every day you're out watering, you're out, and by the way, none of them go to the gym. There's no gyms in this that I know of. There's no Pilates studios, there's no yoga studios, but everybody has a garden. So every day they're out watering or weeding, low intensity physical, digging, harvesting, and they emerge from this activity with what?
Stronger legs.
Stronger legs and fresh
Optimism.
vegetables,
And
you know,
better
and
food.
strawberries and
Sunshine.
things.
Yeah.
So it's this plain sight, accessible to almost every American, either in your backyard or in a public garden. And we know it lowers cortisol, kind of closely associated with the feeling we get from optimism. Regular low-intensity physical activity. We all know we should be eating more fruits and vegetables. Why isn't there a garden intervention at the national level?
Same is true in the Nicoya Peninsula, right? A long history of small shareholder farms.
That's right, Middelpas, yes.
Yeah. What do you think? What is a longevity hack that's sort of hidden in plain sight?
Well, I think that optimism point is key, and it's a really big problem for policymakers, for governments. So a conference like this, where we're talking about healthcare, you know, we should really be talking about the communities and the families that we're trying to curate and create an environment for. And there's a link here with fertility as well. Longevity and fertility are a lot about a belief that your world is going to get better and that your children will have a better life than you will yourself. Now, at the moment, governments are thinking more about building hospitals and trying to acquire more drugs and nurses. I think the challenge for us is to try to match policies that support families, communities, gardens, as well as healthcare systems that treat the sick.
So rebalancing the NHS budget.
Well, it's all tied together, and the doctors of tomorrow, not only will they be prescribing, they'll be handing out bags of carrots in order to try to encourage people to eat more healthily and to rebalance their diet. That may sound far-fetched, but having a more holistic approach to health, encouraging the gym, encouraging healthy eating, encouraging confident families. That's where a lot of the strength we're going to get from, not just from the longevity drugs and the very excellent XPRIZE type hacks that we're going to see in the future.
Right, and Lloyd, there's lots of initiatives now, new data on food as medicine programs, incorporating food and nutrition into the delivery of healthcare systems. Where do you see this going?
Well, I think it's got huge potential and huge necessity. We are what we eat. I think we've, not only in medicine, but just in society writ large. And part of this transformation, we need to be leading in terms of the healthcare we deliver, but also, importantly, we have to change societal attitudes about health and responsibility, because I think in our country and in the United States in particular, we've had a very passive approach in general. I mean, people understandably want to know that if they're sick, they go to a healthcare provider, and that healthcare provider is going to work with them and do everything they can to cure their illness or to forestall its development and to restore them to health. We've had far less emphasis on, well, what can each of us do as a healthcare consumer to maintain our health? And the first step is in what we eat and monitoring what we eat and eating healthily, and then, as Peter was saying, exercising in any number of different ways. But the steps are seemingly straightforward, but it involves a big cultural and attitudinal shift, I think, in terms of the way we as individuals in our society interpret health and responsibility for maintaining health.
Right. There's a big gap between the knowing and the doing. We know that we're supposed to sleep, get a lot of rest, eat well, exercise, but society seems to push us in the other direction.
I think that's right. I mean, I said it before, but the healthy choice is very often the most difficult choice. It's easier to order a Domino's delivery than it is to cook a meal. And I think the medicines that we're creating and the therapies for extending life, they're going to be fantastic, but they won't work if they're building on a fundamentally unhealthy, depressed population. So in order to help the longevity people, we need to fix these societal issues and to step into the vested interests that are creating so many problems for the health of our country.
Peter, I want to ask you, I've read your longevity book. You are very open about all of the things that you are experimenting with or trying in your own body. You've told me that you take rapamycin. You list some supplements that you use. One is called quercetin or quercetin. As I read it, I was sort of wondering, like, how does he know, because he's layered so many things together that you're trying simultaneously, how do you know which ones are working or helping and which ones aren't?
That's a great question. My mom asked me the same question.
Are you sure you
She's
should take
88
these,
and doing
Peter?
great. A few things. Number one, I'm on a constant discovery mission, like Dan, like everybody here. So every year, for example, I go 1 year to the East Coast, 1 year to the West Coast, and I go and I meet with the top 40, 50 scientists, entrepreneurs in the longevity space. I bring a number of family offices with me who are investing in those companies, and it's a great discovery of, like, year on year, leveling up. What are the latest breakthroughs? Where are things going? And so from these longevity platinum trips, I'm constantly learning. The second thing is Tony Robbins and I and Bill Capp built a company called Fountain Life that is sort of the most advanced diagnostics and therapeutics. So what we do there is we digitize people. We upload them. It's 150 gigabytes of data. It's everything knowable about you, all imaging, all omics, everything. And all of that gets fed in on a functional medicine base to the physicians. And I do that full upload once a year, and every quarter, and this is for me tomorrow morning, a series of blood testing. And I'm constantly measuring and moving what's going on. And so that gives me insight.
Okay.
Right? There's a photo they're going to put up. So I wrote a book with Tony Robbins, which is 700 pages, called Life Force, which no one reads 700 pages. It's a great book. It was a New York Times bestseller for 2 months. I put a 120-page summary version of that, and this is in the form of diet, sleep, exercise, mindset, meds, supplements, and not dying from something stupid. So I give out digital copies of this. I mean, the summary is sugar is a poison, period, end of statement. Your body was never intended to consume that much sugar. It's a neuroinflammatory, cardiac inflammatory, it's just not good. You need 8 hours of sleep. You need exercise. Be optimistic. The final thing is, and this is probably the most important, your body is really great at hiding disease. It's really great at hiding disease. You don't know until you look. 70% of all heart attacks have no precedent. You don't feel a cancer or active cancer until stage 3 or stage 4, right? How many of you know of someone who went to the doctor and said, I'm sorry to tell you this, but it didn't happen that morning, right? We don't test for most of the cancers that end up killing you, glioblastoma or pancreatic cancer, right? So how do you know? You've got to look, right? And people say, I don't want to know. Bullshit. You want to know. You're going to find out eventually. You want to know now or when it's too late. So I urge you, through whatever mechanisms, if you're here in the room, you can afford to be looking. There are lots of different places you can go. Fountain Life is just one of them. Please look. I'll leave it at that.
I want to ask specifically about rapamycin because I think there's a lot of intrigue and mystery around it. And there's lists constantly being published of Silicon Valley billionaires taking rapamycin and sort of looking at this from the outside, wondering why are people taking rapamycin? What's the evidence for it? And will there ever be a clinical trial to determine if it is a longevity drug?
So I'll add a little bit, and I welcome my panelists here. So I take 6 milligrams once a week, right? This is not an immunosuppressant level. And the work that's done, if you look, I mean, across scientists, it is probably rated the #1 most likely to be pro-longevity. The studies have not been completed yet.
But it began as a drug for transplant patients,
yes.
And it would suppress immunity. But you're saying at the dose you're taking it does not.
Anybody want to add to this? Anybody else taking rapamycin on the table here? No? Okay. So the studies are hopefully being kicked off this year. I know the Buck is looking to get that study funded. And right now, again, in animal studies, in large animal studies, rapamycin is a pro-longevity. I used to be on metformin. I've stopped taking metformin. I switched over to berberine because my mission last year was to add 10 pounds of muscle, which was not easy.
But I did it. Yeah.
And I raised my protein intake to 150 grams, 1 gram per pound. I work out 5 days a week. I added other essential amino acids and other elements, but it was a mission that it was like my #1 objective to do that. That and 8 hours of sleep.
Dan?
I have 2 revolutionary supplements to tell you all about. If you look at the world's longest lived people, if you want to know what a centenarian ate to live to be 100, you have to know what he or she were eating his whole life. As a little kid, middle age, lately. And so we did a meta-analysis, 155 dietary studies done over the last 100 years. And we found that people who are actually making it to 100 eat a cup of beans a day. It's associated with about 4 extra years of life expectancy. So if you want to take a supplement, take about 80 black beans a day. And if you don't like beans, we also found that people who eat between 15 and 30 walnuts a day are living about 3 years longer than people who don't eat walnuts, and you don't even need a prescription.
All right,
How about olive oil?
Olive oil, I'm all for olive oil.
Yes, olive oil shots.
Yeah. Yeah. Tell me about quercetin. I mean, there's quercetin in apples and in fruits. Why do you take it as a supplement?
I'm sorry, for quercetin?
Quercetin, yeah.
So listen, one of the things that's going on in the body right now is your cells divide about 50 times. It's called the Hayflick limit. And at the end of that division, it should have the decency to die. Sometimes it does not, and it becomes a cancer cell, where it's immortal and continues growing. Other times, it will become a senile cell. And these senile cells are sitting around and generating inflammatory factors, right, in your skin, in your liver, and all of the organs of your body. And quercetin is one of, in combination with other meds as well, a senolytic. So the idea of and there are lots of different, there's NK cell approaches, there's a lot of work being done right now in this. Can we give you a therapeutic that will go and kill these senile cells that are generating these inflammatory factors and make the room for them to be replaced with younger, more vibrant cells?
Okay, so senescent cells are cells that have stopped doing the work they're supposed to do, but they're not dying off, so they're flaking off little
Grouchy
inflammatory
old
bits.
men cells is another name for them.
Got it. So there's a whole lot of research, Kristen, into drugs that could be senolytic drugs. I was reading about a trial that turned out to kind of be a failure of an early candidate. Talk a little bit about sort of the graveyard in biotech, like how many things are explored and don't kind of pan out. Do we know everything we need to know about senolytics, or was just this particular compound not effective?
Sure. I mean, I think senescent cells as a concept are really well validated. I think they've been described most vividly as zombie cells, right? There's these cells that persist, they're not doing anything useful, and if anything, they have toxic impacts on their neighbors. And it's been shown by a lot of different groups that if you can take a middle-aged animal, you can delete them somehow, then that's actually hugely beneficial for function, for lifespan, for health span. But the question is, how do you delete those cells while sparing your healthy ones? And this is a tricky problem to solve. It's the same reason why like cancer drugs are tricky, right? You have to kill the bad cells while sparing the good cells. And so most companies are still in the very early stages of figuring out how to develop very specific medicines that can go into an already old person with established these cells throughout their body and specifically delete them. So there was, yes, one high-profile clinical failure recently with the first such target, but keep in mind that these are early days, right? Like biotech drug discovery is hard. It's a matter of finding out which target to go after and selecting the right patient population and the right indication. And I think what Peter mentioned.
You said the right patient population is really important, right?
Yeah.
Because they might have been a success with a different population of patients.
That's right, yeah. And just to give you one example, because this first drug that had challenges in the clinic was really related to, it was a cancer drug where there were some toxicity issues too, potentially. One of the really cool early science approaches is that your body, when you're younger, can clear these cells on its own, right? So can we learn how that process already works? Can we leverage that? So I think we're going to see a lot more hypotheses tested rigorously in the clinic. But yeah, just to emphasize, right, it's not only a matter of figuring out the right target and the right medicine, it's also the right patient population to sort of even see your effect, right? So these are all hard steps, and this is really a very nascent industry.
Chris, can I ask, as a researcher, is this decade different than the last decade in terms of the tools you have to do much more per dollar per person?
Yeah, definitely in the clinic, right? So this is an area of science I've grown up in, for my PhD, my postdoc, and then at the company. And there's a few different things that are coming together at once. Once I think, so even separately from the technology angle, aging science is mature now in a way it isn't before. So there's like a dozen plus programs in serious, well-powered clinical trials that are really testing, mechanisms that have the potential to impact aging, which is so exciting. But to your point, Peter, I think that the new tools are so enabling, right? Because usually when you want to test a particular hypothesis, especially if it's aging, you have to go into a very large trial and look for a small effect that might unfold over years. And I think that by being able to select the right patients where they can have a large effect, biomarkers, data sets, AI are really helping us with early clinical de-risking. So it's all about doing your first trial to see that first hint of effect in a human, because that's still like the challenge in biotech in general. We're so terrible at predicting what happens in a human, even if it works awesome in an animal. So I think that the new data sets, the new methods, the new human data in particular are helping us be very specific in the clinic, which will let us test more hypotheses in parallel and advance more medicines.
Lloyd, you've written a lot about precision medicine. So as you listen to this, is it possible that a senolytic drug that works in one person doesn't in another?
Well, just to follow up on something that Kristen said, we're 50 minutes into the discussion, and Kristen just mentioned AI. So I do think that we're at the cusp of a revolution, all the way from fundamental biology, being able to focus hypotheses, even determine hypotheses, hone hypotheses from generative AI, to accelerating processes of drug discovery, making the processes that Kristen and colleagues work on every day more efficient, more effective from both a time and a cost point of view, and radically transforming the way we do clinical trials so that we can really glean an understanding of which population of patients would benefit from an intervention in ways that have been very laborious and expensive and often ineffective in the past. So I think we're just now coming, and I wouldn't say that we've come to grips with how generative AI is going to change processes all the way from fundamental biological discovery up through the design and conduct of clinical trials, including, by the way, how we educate physicians, continuing to move away from a memorization-based curriculum and more problem-solving and learning how to use the tools that are now at our fingertips. But this is going to be a really exciting decade that I think is going to be transformed by AI if we deploy it the way we should, and that is ethically, with a clear knowledge of what we need to protect. At the top of the list is the primacy of privacy, as well as the responsible use of AI so that it doesn't perseverate and exacerbate the biases that already exist within the system.
Kristen, I want to go back to you, and I think because there's such intrigue about the GLP-1 agonist drugs, the Wegovy's of the world, because they are a blockbuster class of drugs. I want to come back to you. The compound that you're working on is a small molecule compound you'll be testing. It can be delivered in a pill. It also, as you mentioned, might mimic some of the effects of exercise, might help promote better body composition. At a time when there's such discussion about these GLP-1 drugs, from a cost point of view, they're about $1,400 a month. You hear a lot of stories of people who benefit greatly, but also have GI distress or sort of lose their appetite. I'm wondering if you were thinking about your molecule as a potential kind of maintenance molecule. Is this something that people could do after they lose weight? Or is this something that will only work in combination?
For sure. So we're still very much in the early days of weight loss therapies, right? There are medicines now that are tremendously effective, but they're imperfect in many ways. In terms of their tolerability, a lot of people have experienced side effects in terms of the price points as well, right? So just to give you a few examples, right? Like the injectables right now, Mounjaro, Zepbound, et cetera, they're super efficacious. You can lose up to a quarter of your weight in a year, but they have these side effects, right? And what a lot of companies are trying to build now are, like, ideally small molecules where over time the cost of goods will be substantially lower, right? Which can help with reimbursement, which can help with broader deployment and production. So small molecule, oral medicine, better tolerated, and also helping promote healthy weight loss. So this is really where the field is moving, I think, in the future, and everyone is looking for mechanisms that, like, to your point, right, you could envision a future. I mean, I think what everyone is coming to grips with is the fact that these are not one-and-done therapies. Because, of course, you can go on one of these medicines, you can lose really a transformative amount of weight if you're overweight, but then once you get off, you generally regain that pretty quickly. You sort of go back to normal. So these are going to be chronic medicines, and especially if we think of these as going on for several years, not just 1 year, then you have to worry a lot about tolerability, right? Like, people are willing to put up with that for a short amount of time, but not forever. And so we really think that the field, and I think there's a number of companies working in this space, trying to come up with medicines like ours that have that potential to be well tolerated, to be used more chronically, and help maintain healthy body composition over a longer period of time.
Got it. We have just about 5 minutes left. I'm going to take one question from the audience and ask it to each of you. Will we all be taking rapamycin or some other life-extending drug 20 years from now? James?
Oh, for sure. I mean, the exciting progress we're making in the therapeutics is surely going to transform opportunities for people to live longer. But that isn't the only thing that's going to happen. We're also going to have to, as described earlier, sort out our own personal habits, and those healthy habits are absolutely fundamental to having a healthy platform.
They're sort of the foundation.
That's the foundation. And we do have to address the environment that we live in and the societal norms around health. We just don't prioritize it enough. We've given too much space to people who, frankly, are making money out of our poor health. and there needs to be a transformation in the way in which we live in order to give those drugs and therapies a chance.
Dan, rapamycin, are you sticking with beans?
Yeah, like you couldn't have predicted when Alexander Fleming was going to accidentally drop orange mold on a petri dish and develop penicillin, which was the biggest innovation in raising life expectancy we've seen in the last century. We're not there yet with any drugs. I think you have to be careful about what you wish for with these longevity drugs, because in many cases, you look at Italy, for example, where life expectancy is going up, but they're just a sicker population that's living longer. And there's so many different systems at work in our bodies. There's our knees, our brains, our eyes. So if these longevity drugs don't address the entire system, we might just be creating a bigger healthcare problem. And the other thing is, in many cases, they just elongate a crappy life. And just for a pitch to these blue zones areas, these are places where they're not only living longer, they're among the 10% of the happiest places. You talked about optimism before. And they get their longevity by being close to nature, growing their own food, having dinner with their family, having a sense of purpose, having a rich spiritual life, walking outside and bumping into their friends. So for right now, I still argue that there are better answers out there among the populations that are achieving it. But I applaud my fellow panelists, because I do believe eventually there's going to be a major breakthrough that makes the human species better.
Yeah, Peter, lifespan increased by about 60% between 1900 and the year 2000 due to antibiotics, clean water. To get to get that next jump, will everybody be taking rapamycin or some other?
Well, I'm definitely going to go find some black beans and walnuts for lunch. So here's a question for you guys. You've got the same 3.2 billion genes from your mom and your dad when you're born, when you're 20, when you're 50, when you're 100. Why do you look different, right? Why don't you have a six-pack when you're 90 years old? And it's not your software you're running. It's what genes are on and what genes are off, right? That's called your epigenome. And today the hottest area of research is, can we reset your epigenome to your younger age? And in a lot of animal models and even into primates, the belief is yes. So will we be taking an epigenetic reprogramming gene therapy or drugs in 20 years? I think 100%. Here's the question. Do you want to live to 120? Not in a wheelchair drooling, but what if you have the aesthetics, the cognition, the mobility that you had at 50, right? I think it's the largest business opportunity on the planet. AI and longevity, there's nothing bigger than those. So, yeah.
Kristen, 20 years from now, we're all taking some kind of anti-aging drug.
I mean, definitely, right? Like, in a sense, that's already true today. Most older people are on a statin, a metformin, something to delay or prevent disease. And I think that there's a lot more coming down the pipeline. As we touched on earlier, we're in very much the early days of the field, and we know from all our work in animal models, there's a lot of very potent levers on biology. I mean, as Peter mentioned, there are a lot of examples in nature of animals that can live healthy and well until they're several hundred years old, which is amazing. So I think we're going to see a lot more exciting medical developments.
All right, Lloyd, you have the last word with less than a minute.
Yes, I think we'll be taking anti-aging drugs. And I would just close with a point of optimism. You know, every summer we have a reunion of patients who've undergone bone marrow transplantation, stem cell transplantation at Stanford. 25 years ago, bone marrow transplantation was oftentimes not successful. It was a difficult therapy to develop. It's now a refined form of therapy for people who have cancer that recurs and fails other treatments. And it's so inspiring to see hundreds of people and their families, their children, their grandchildren. Most of these patients, now free of disease, wouldn't be on this planet today if it hadn't have been for the work that so many did to perfect stem cell bone marrow transplantation. We're going to see that story repeated time and time again, and in a way that doesn't just come at the very end stage of a disease, that predicts or prevents the disease or forestalls its development altogether. And that's what makes me so optimistic about the future.
Thank you very much to a wonderful panel and a great audience. Thanks for being here.
Thank you very much.